seminar series, Difficult Conversations. This is our first seminar for the 2020 year, and I hope that you have joined us for past ones so that you can view those also online. Today, it is my pleasure to introduce Dr. Fatima Cody Stanford. She is an obesity medicine physician scientist at Harvard Medical School and Massachusetts General Hospital, where she provides behavioral, pharmacologic, and bariatric surgery care at the MGH Weight Center. Her current research focuses on obesity, health disparities, and health policy. Dr. Stanford received her BS and MPH from Emory University, her MD from the Medical College of Georgia School of Medicine, and her Master's of Public Administration from the Harvard University Kennedy School of Government. Upon completion of her MPH, she received the Gold Congressional Award, the highest honor that Congress bestows upon young Americans, and it was presented to her by Congressman John Lewis, her home congressman. In 2019, she was selected for the Massachusetts Medical Society Suffolk District Community Clinician of the Year and for Reducing Health Disparities Award. So please join me this afternoon in welcoming Dr. Fatima Cody Stanford. Thank
you. Good afternoon, everyone. Oh my goodness, you guys, I'm about to pour my soul out. Let's try that again. Good afternoon. So I don't think I knew that this was difficult conversations, but I do want to say that this will be indeed a difficult conversation. In this particular talk, we're going to talk about racial profiling in health. I want to thank Dr. Dean Cozier. I want to thank the Boston University School of Public Health for having me here talking about this issue that is very much germane to my heart. What you will find during the course of this presentation is that it will be very raw and authentic. And I really hope that you'll go on this journey with me as we look at this issue of racial profiling in health here in the United States. So I'm going to start with a key quote from someone that you guys embraced very much here at the Boston University, and it is one from Dr. Martin Luther King Jr., which states that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So that's how we're going to lean ourselves. We're going to glean how we're thinking about this issue of racial profiling and how it impacts our health. But we're going to also look at issues in terms of disparities, because I couldn't help but to touch that, as this is definitely what I do in my work. So let's talk about bias here in the United States. One of the most common forms of bias in the United States is indeed race bias. So when you did a Google search, believe it or not, as recently as 2016 for young black teens, you were met with mugshots, much like the ones that you see above here. If you did the same search for young white teens, you were met with smiling faces holding things like a soccer ball, a football, U.S. football. I know there's the persons that are not from the U.S. that are here, basketballs and things of that sort. This was reported back in the Washington Post, and after that was reported, you can imagine that Google did change their algorithm such that if you did a search for young black teens, you no longer only met with mugshots of young black men. During this talk, we'll come into talking about issues such as weight bias, and the reason why that's important is because as of this time, the only thing that surpasses race bias in the United States is weight bias. It's the most common form of discrimination and bias in the United States. We'll come back to that, but I do want to start off, because we are talking at this very moment about race bias and how that impacts what we do. So we're going to change stories, and we're going to talk about my life in race bias. This is going to be something that just happened within the last, 13 months. So we're going to let Lester Holt take it over for us.
General Hospital, so as a doctor, it was natural that she jumped in to help a passenger in distress on a Delta flight this week. But it wasn't as simple as that. Here's Kristen Dalton.
When Dr. Fatima Cody Stanford saw a fellow passenger hyperventilating, she started to help. A flight attendant asked if she was a doctor, so she took out her medical license. Then a second flight attendant asked if it was really hers.
people traditionally see a physician as a white male, and for many obvious reasons, I do not fit that bill.
Stanford tweeted to Delta, very disappointed that your policies on diversity have not led to any change. Flight attendants would no longer require passengers to show medical credentials before offering assistance. Now the airline is apologizing, saying we thank Dr. Stanford for her medical assistance and are sorry for any misunderstanding that may have occurred. Celebrating diversity. What a doctor looks like is trending on social media.
So I'm going to stop there because I think it's very important to recognize that I have 4 degrees. Yes, 4. I may get a 5th, you guys. We'll find out soon. I'm actually serious, which is much to my husband's dismay. 4 degrees, did 2 residencies, have done 2 fellowships, and actually had my medical license on me on this Delta flight from Indianapolis back into Boston. The flight attendant had the audacity to ask me if it was really mine. Now, if I were smart and if I had that bias, if I was that flight attendant, I would have just checked the seat map, and since the name matched, Fatima, Cody, Stanford is not common. Actually, there's no other Fatima, Cody, Stanford. Just Google it and check me there, but I can tell you there's not. But it didn't matter on that flight coming back in on October 30th, 2018, back into Boston. What was very interesting about this particular issue that happened is that just 2 weeks before at the Massachusetts Medical Society, we decided to do an entire conference on bias in medicine. And as our keynote speaker was Dr. Tamika Cross. Dr. Tamika Cross was the physician that was on a Delta flight in 2016 when she was denied the ability to render care to a fellow passenger. I introduced her on the stage, much like this, and felt as though that issue had been somewhat remote. It was 2016, we were in 2018, introducing her about her particular flight issues. And when this occurred, exactly 12 days after I introduced her on that stage, she was one of the first people to contact me, and she said, Fatima, no. She had spent the last year and a half flying out to Delta's headquarters in my home city of Atlanta, working with Delta high level of leadership to work on changing their policies surrounding diversity. But despite that, one of her close friends was indeed experiencing the same thing. So our degrees don't protect us. I knew that before. And people always say, well, gosh, that is such a really, a horrible thing for you to deal with. But you're going to learn why this pales in comparison to what I experience on a daily basis as a physician here in Boston, Massachusetts. I'm going to take you from my early childhood or infancy, and this is actually me, right? That's cute, right? I thought we transitioned from sadness into goodness. This was me. This is actually my first memory in life, the day of my christening, and I do remember it. From the vantage point of being inside of me, like I'm looking out to you guys, I know that my grandmother and my mom were trying to decide how they were going to lay me so that the gown laid appropriately. I think it came out okay. But what we do know is, as a black girl that was born in the late 70s, what I was entitled to, what my trajectory was very different. Looking at life expectancy, even starting at birth. Now, I was born in the 70s. You can see this starts at 1980 to 2014. But look, as a black girl being born, black, not Hispanic specifically, infant deaths being the highest there, as you can see on this chart, taken from the Centers for Disease Control and the National Center for Health Statistics, followed by American Indian or Alaskan Native that are not Hispanic. And you can see we have a drop-off to those that are of the majority population, white, non-Hispanic, Hispanic or Latina, and then Asian or Pacific Islanders actually having the lowest likelihood of having infant deaths. Obviously, I survived, so that's good. But I was set up for failure from the moment that I came into this earth. This young girl, this young infant, who is now this woman who still to this day experiences biases in my everyday life. And thinking about how it impacts my health and my overall health, how it impacts the health of my family, is something that I think about quite a bit. So we're going to go from the age of 3, and I'm going to take you to my 4-year-old picture. This is me shining very brightly here in the middle. I remember this day very clearly. I remember telling the photographer, I want to be the person standing behind the sign. And he's like, okay, whatever, 4-year-old. And he allowed me to do that. I actually saw my 4-year-old teacher, this is Miss Range, for the first time in over 40 years over the Christmas holidays this past year. And it was interesting to hear her talk about me and things that were of interest to me. We were given an assignment to determine for the bulletin board what our profession would be. And I told Ms. Range that I wanted to be 3 things. And she says, well, no, you can only pick one, Fatima. And I was like, well, but I want to do 3 things. And she said, okay, we're going to have a teacher-parent conference because that's deviating from what we're supposed to do. So my parents showed up for the parent-teacher conference, and I got my wish of having 3 professions listed. They were as follows: physician, attorney, actress. I feel like I'm acting right now a little bit, right? So that we got checked that. The attorney thing, I don't think we're going to do that. Physician, I research, I teach. I do quite a few things, so I think actually I could have gotten about 5 things. But I really want to take you back because I was hearing stories from my parents also during this time about what it was like moving into their neighborhood. When my mom was pregnant with me in the 70s, and these stories that I were hearing are stories that most young kids that don't look like me, that aren't black and brown like me, wouldn't have to hear. But let's look at it. So when my mom and dad moved into their neighborhood in Atlanta, Georgia, yes, Atlanta is by far Chocolate City, but there are still, if you are just step a little bit outside of the city, you see issues like this. So my parents were met when they moved into their neighborhood with a cross being burned on their lawn by the Ku Klux Klan. I remember hearing these stories from my parents, and my dad is like, Fatima, you didn't see it. And I was like, I feel like I saw it, but maybe it's because I was in utero. That I felt it. But how do you explain? How do parents of young black and brown girls and boys, don't worry, I didn't forget you guys, prepare themselves for the world that they now inherit? These are the stories I was hearing. These are the things that were happening to my parents as they were starting their new life, their new family with their first child. This is how they were greeted. I remember growing up in Atlanta and seeing marches that were going on in Forsyth County, led by civil rights hero Jose Williams, who's no longer living, being terrified to go to those areas because I knew that if I looked the way I did, which is obviously the way I look, I would not be welcome. And so this is the world that my parents had to bring me into. So let's look at racial profiling. And here we see some names or faces of names that are very familiar. We have everyone from Trayvon Martin, Renisha McBride, Eric Garner, Romaine Brisbane, Michael Brown, John Crawford III, Jonathan Farrell, Dante Hamilton, and Tamir Rice, just to name a few. And some of these stories we've seen make major news, and a lot of what happened to them really had to do with how they looked, the skin that they inherited, not their character. And so I wanted to talk about racial profiling. Racial profiling is an act of injustice that uses race as the foundation for shaping perceptions and behaviors associated with defining who is and which groups are designated as criminal. For individuals that are disadvantaged from racial and ethnic minority groups, this is where we see this, and it's applied to stigmatize, to stereotype, and to target individuals of color. So let's talk about how this idea of race impacts the care of even the very powerful here in the United States. In case you guys didn't know, this is Queen Bey, or Beyonce. On the right side, Serena Williams, tennis phenomenon, most winningest and I think highest paid female tennis star of all time. And they shared their stories of what it was like to be black and pregnant. And the stories that they shared were not ones that were wonderful. despite their celebrity status, often being treated that their symptoms that they were presenting with were unwarranted, unfounded, unjust. Beyonce with her twins being diagnosed with preeclampsia, having to have an emergency C-section. Serena Williams having difficulty breathing, a history of having DVTs or deep vein thrombosis and pulmonary emboli, so big clots in the lungs, telling the nurses that, look, I cannot breathe. That reminds us of someone on the previous slide, having to be placed on blood thinners for long term to treat what was a pulmonary embolism that she experienced right after the birth of her daughter. And what we do know about outcomes, particularly maternal outcomes of people that happen to be celebrities and people that happen to not be celebrity, is that Black women and their children fare far worse than any other groups, despite education, despite socioeconomic status, and it's something that we're failing Black women with. And so we have to do better. But I think why it was important to see these prominent figures come out is to say that it can happen to anyone. So let's take a look and shift some gears. We talked about maternal care. I want to talk about the drug crisis in the US. And this is kind of comparing the 1990s versus today, or I can even say the 1980s. And so we had the crack cocaine epidemic that was very prominent back in the 1980s, early 90s. Nancy Reagan and her drug-free campaign. And then we have the opioid epidemic of today. And there's some major things that we should contrast when we look at the two epidemics. The crack cocaine epidemic primarily impacted persons that look like me. And let me tell you, it was not a major issue tackled by any of our major medical organizations here in the United States. But when the opioid epidemic really became of paramount importance, because it particularly impacted majority populations, we began to see medical groups, the government as a whole, come forth in full-fledged with weaponry, I guess, to really begin to address the opioid epidemic, because it didn't address primarily people as much that looked like me. And there's a history of why this is. Let's take us back, but before we do that, let's look at something that disproportionately impacts communities of color and how we treat the individuals associated with this. We're talking about sickle cell disease. So sickle cell disease occurs in approximately 100,000 Americans today. It does disproportionately impact those that are African American, 1 in 365 African American births. And you can see 1 in 16,300 Hispanic Americans. When persons arrive into the emergency department with what's called a sickle cell crisis or things, often they are not administered adequate pain medication. And there was a large article that came out in the latter portion of 2019 that said, well, that we did them some good. They're not hooked on opioids because we didn't treat their pain. And I would say that that's not the way we should think about it. I think we should adequately treat pain when it does exist. But we should not assume that just because you are brown, that when you come into the emergency department, indeed in a sickle crisis, that we do not treat you appropriately. This was such a big issue that Kaiser Permanente actually came out with this entire slide about the 5 myths about sickle cell disease, and they debunked them. So let's go through the myths that are there. Number 1, sickle cell disease is a Black disease. No one else gets this strange disease. That was the myth. Fact is, sickle cell disease isn't exclusive to those of African descent. It's also found in people of Indian, Middle Eastern, Hispanic, and Mediterranean ethnicity. Fact or myth 2. Sickle cell disease is contagious. I don't want to catch it. 2, you can't catch sickle cell disease. It's a genetically inherited disease passed down from parent to child. Both parents must carry the sickle cell trait for a child then to inherit sickle cell disease. Number 3 myth, a person with sickle cell trait automatically develops sickle cell disease. Incorrect. The fact is that sickle cell trait is very different from sickle cell disease. If an individual carries the sickle trait, it doesn't mean they will have the disease. Someone who develops sickle cell disease must have 2 sets of the sickle cell gene to then develop the disease. Number 4, which I touched on a little bit before, people with sickle cell disease are drug users and abuse pain medication. The fact that it's associated with this, that studies show there is no increased substance abuse in patients that actually have sickle cell disease. And then finally, number 5, there is nothing a sickle cell disease patient can't do except take drugs daily and suffer. And it says that while medication is necessary, there are lifestyle changes that have helped reduce crises. And these include things like good nutrition, acupuncture, yoga, and reducing stress. But let's look at this war on drugs, and let's look at where this all started here in the United States. You might notice that our former president, Richard Nixon, is at the top. You may be less familiar with this gentleman at the bottom, who was the domestic policy advisor for Nixon, John Ehrlichman. And this is one of his quotes. We'll look at another quote right after, but one of his quotes was as follows. Look, we understood we couldn't make it illegal to be young or poor or black in the United States, but we could criminalize their common pleasure. We understood that drugs were not the health problem we were making them out to be, but it was such a perfect issue for the Nixon White House that we couldn't resist it. He goes on to state the following. We knew we couldn't make it illegal to be either against the war on blacks, the war or blacks, I apologize, but getting the public to associate the hippies with marijuana and blacks with heroin and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know that we were lying about drugs? Of course we did. So the war on drugs, the proclaimed war on drugs, was set up to disenfranchise a group that was already disenfranchised. In case you guys didn't remember, 400 plus years of slavery here in the United States, Jim Crow era, coming right out of Martin Luther King's assassination. This is what the Nixon White House decided to do. So let's look at what happened, president after president, as we really tackled this issue of looking at the drug crisis. And we're going to start with Richard Nixon here. America's public enemy number 1 in the United States is drug abuse. But you understand now where the origin of that is. We'll go to Gerald Ford. It says, I've directed all agencies of the federal government to step up law enforcement efforts against those who deal in drugs. So that kind of continued the thought. Then President Jimmy Carter from my home state of Georgia says that penalties against possession of a drug should not be more damaging to an individual than the use of the drug itself. So a different thought process, finally. Ronald Reagan states, the fact is nobody in the US government ever had anything to do with running drugs to support Nicaraguan resistance. I will stand on that to my grave. George H.W. Bush, when you mention the war against drugs, for the most part, you're referring to policies, a political agenda. Bill Clinton, I have a brother who's a recovering drug addict. He didn't know the right words to use, but I'm very proud of him. But I can tell you this, if drugs were legal, I don't think he'd be alive today. George W. Bush, the media won't let go of these ridiculous cocaine rumors. You know, the truth is, I honestly don't remember whether or not I tried it. We had some pretty wild parties back in the day, and I just don't remember. Barack Hussein Obama, drug use is a serious problem, and I've long supported strong anti-drug legislation. But in addition to being tough, our drug law should be rational and fair. My bill achieves the right balance. We've talked about the need to address this cocaine sentencing disparity for long enough. It is time to act. I did not cover the current occupant of the White House. I don't know what his stance is on really most things, so I couldn't capture it here. It could change on a Twitter thread during the course of the talk. But what I can say is that what we do know is that with the criminalizing of particularly black men, is that black men were being locked up in prison and had prison sentences that were by far exceeding those of majority populations for the minimal possible possession, often for marijuana. And those sentences are still in place for many of these black men who are by far the largest population in our prisons here in the United States. So we're going to take a little bit of a shift because we're going to come back to me, and so I'm going to pour out a little bit about myself. This is about my medical school journey. Obviously, this large picture to my left is definitively me. This is me here, also me with mom and dad. Husband's there, so my sister's also there. And let me tell you, it's exciting, right? We're finally going to medical school. It's something I dreamt about. It's something I had said when I was 4. That was the first thing I wanted to be. And so when I started at the Medical College of Georgia and that was founded in 1828, in the early 2000s, I decided to run for class president. One of my classmates from the Harvard Kennedy School is here in this audience. And he, you would have expected me, right? Probably to run for president, right? So I ran against 3 white male opponents, and I won as the first black class president in the school's history. The school was founded just a few years ago, 1828. And I was serving as the first black class president. So that was pretty exciting. I was excited. It was a time of significant importance, a time of great knowledge acquisition. But I want to take you to what I was introduced to pretty early on after being elected. I was introduced to the historian of the Medical College of Georgia soon after I won. She was excited to meet me. And she took me on a field trip, for lack of a better way of saying it, through the archives of the Medical College of Georgia. And so what I noticed when I was looking through the archives was this young black man. So I told you that the medical school was founded in 1828. We all know that slavery was alive and well in the antebellum South. But he was in all of the pictures. So of course I inquired to the historian. I said, well, who is this guy? And she says, oh, I'm so glad you asked. And let me tell you who this was. This was Grandison Harrison. He was a slave that was owned by the faculty. All of the faculty owned a piece of him. He was purchased in 1852 to do one primary thing, to rob grave sites, particularly from the Cedar Grove Cemetery, which is where the poor and black were buried. So they would have cadavers with which to learn medical knowledge. It was illegal to dissect cadavers in the state of Georgia until 1887. I told you he was purchased in 1852. In 1887, his talents were still needed, meaning he needed to be the person that would go out and rob the grave sites because they didn't have enough bodies being donated so that these gentlemen could learn anatomy. He served other roles. He was a porter, he was a janitor, he was other things. And eventually in 1908, after slavery, of course, ended, he actually retired as a full-time employee of the Medical College of Georgia. People came to know who he was in his role back in 1989 when they were doing excavation at the old medical college. That's my medical school class. At the old medical college, they began to do excavation, and they were trying to figure out what's going on. They were seeing all these old bones. These were the bones that were buried, because remember, you weren't supposed to be dissecting bodies, but they buried these under the floor of the old medical college, which still exists there. You can see we still memorialize it. But instruction took place in the old medical college from 1865 to 1913, and they were just discovering this. Well, I was appalled, not surprised, but appalled that this was indeed the case, that this slave, Grandison Harrison, who played a large role in the early education of my medical school, had gone through what he had gone through, but I was even more appalled that no one had ever acknowledged his value or his worth or his contributions. So as president of the class, the first thing that we do, or the most important thing we do as a first-year class, is a cadaver memorial ceremony. When else would we acknowledge the contributions of this gentleman to the education? I took this back to my classmates at the Medical College of Georgia, specifically the 17 elected officers, and they were infuriated with me that I would want to acknowledge this gentleman and his contributions to the education of the early medical school classes. They said I was bringing up the dirty laundry the audacity of me to do that. And let me tell you, I went from being president of their class to the subject of an anonymous newsletter that went out to the entire faculty, student, and staff, in which they ridiculed me for the size of my lips, the width of my ass, the contrast of my teeth color to my skin color, their beloved class president. Every day in class, I would have things thrown at me. Every single day. So often I wouldn't go to class because I didn't want to have something thrown at me while I sat there, because I took time to acknowledge this historical figure who's now memorialized in the Smithsonian Museum. So when people ask me about that Delta Airlines flight, and was that really hard to deal with? Let me tell you what was much harder to deal with is this. These are my classmates who they've elected for me to be class president, but they're my classmates that know my value, my worth. They know that I'm a medical student. They know who I am technically. And even in this population, I am really ridiculed, I am ostracized and dehumanized in a way that is completely unacceptable. And here we have these as your practicing physicians here in the United States. We're going to shift and talk about what I do for a living. So I'm an obesity medicine physician, and I would be remiss not to actually educate you guys about obesity, the disease. In 1913, the American Medical Association decided to acknowledge obesity as a chronic disease, and I was a speaker right before they had that infamous vote. We learn about body mass index, and there's some flaws with body mass index and how we look at weight and weight status, but you can see here that we do have some gross generalizations that we can apply to population or research-wide studies, where we look at weight status, persons that are underweight having a BMI of less than 18.5, people of normal weight status having a BMI of 18.5 to 24.9, those with overweight, 25 to 29.9, and then we get into our three classes of obesity, class 1, class 2, class 3, mild, moderate, and severe. A BMI of 30 to 34.9 being mild obesity, a BMI of 35 to 39.9 being moderate obesity, and then greater than or equal to 40, severe obesity. There are a few things that we do. We talked about weight bias being by far the most common form of bias in the United States, and even in the language that we use when we're talking about people that have excess weight, we show our biases. We refer to these patients as obese. I'm going to ask you to delete the word obese from your definition or from your vocabulary, because these people have the disease of obesity. I never refer to patients as obese. We use also stigmatizing terms such as morbid. If someone happens to fall in class 3 or severe obesity, that's also stigmatizing. We don't say morbid to talk about someone that has cancer. We don't say morbid to talk about someone that has severe heart disease, but we say morbid when it should be severe obesity. So there's a lot in the language that we use and in what we deliver in terms of our care to patients that's highly stigmatizing. What you can see is that obesity is by far the most prevalent chronic disease, not only here in the US, but around the world. At the top, you can see that about 40% of the US adult population actually has this disease of obesity. Approximately 19, or actually about 20%, that are in the pediatric population, that's 20 and under, have the disease of obesity. So pretty sizable portions of the population. I want to take us over to some maps based upon the US, and this is just starting at 2011. This is taken from the Behavioral Risk Factor Surveillance System, and I want you to take a peek at just the US map here and take a peek at the percentages of obesity. Less than 20%, you can see no one fits that criteria, and this is on self-report data. So I want you to think about whether you self-report things correctly in terms of your weight. So this is probably an underreport, right, you guys? We all know that. 20 to less than 25% here in green, yellow, 25 to 30%. And as we get into crimsoning of the map, it actually is a bad thing, not like Harvard crimson, but it actually is a bad thing. So I want you guys to look at US adults from 2011 to 2017 and look at how quickly the map shifts. When we start looking at obesity rates by self-report data, and 2017, which is the most recent data. So if we look at 2017 data, you can see there's been a shift such that we have quite a bit of the Southeast having rates of obesity greater than or equal to 35% based upon self-report data. But what I want to do is I want to look at the difference between race and ethnicity, specifically race, and look at how this differs amongst different cohorts. We're going to start looking at non-Hispanic white adults from 2011 to 2017. And so what you can see here is that only West Virginia gets picked up as having a sizable portion of the population that has obesity when we look at non-Hispanic white adults. So let's shift and let's look at what happens when we look at Hispanic adults and see how the map does indeed differ from the previous map, such that if we look at the map that was prior to that, where we looked at white adults, and we compare that to this map where we're looking at Hispanic adults, we do see that quite a few states have been picked up in terms of looking at the rates of obesity in those states. But what really drew me to this work was not either of the two maps that you just saw, but indeed this map, looking at non-Hispanic Black adults here in the US and looking at obesity rates amongst my cohort. I don't think we live in South Dakota, that's one thing, so if you guys are wondering about that. Montana, Idaho, I don't think we live there either. But let's look at what we're seeing here. We're seeing almost a completely crimson map. What we do know if we look at Black women, for example, the group that I would represent, is that 60% of Black women here in the United States actually have the disease of obesity. 60%. Another 20% have overweight, which means that 80% of African American women, and I'm thinking about my African sisters in the room, but we're talking about persons of African American, have overweight and obesity. 80%. We can't say that about any other disease process. And the reason why this is important is because it really impacts every organ system of the body. It can cause migraine headaches, nephropathy, so kidney issues, metabolic syndrome, type 2 diabetes, joint disease, causes problems with your urination, your heart disease. I mean, it really affects every organ system. The reason why I do this work is because if I can address or treat your obesity, then I have a downstream impact on multiple organ systems. There is no other disease that I can treat in which I can get that level of response. But let's look at this and how these diseases are disproportionately impacting communities of color. Heart disease is by far the leading cause of death for women in the United States. About 1 in 16 women aged 20 and older have coronary heart disease. You can see there are some differences. Black women having the highest rates. This is actually statistically significant for those people that are in the audience thinking about that. And the risk factors for heart disease amongst Black women and Latinas, for example, is overweight and obesity, which you can see is very prominent in Black women and those of Hispanic origin. Diabetes, you can see that 11% of Black women, 15% of Latin women. High blood pressure, 53% of Black women, 30% of Latinas. Lack of physical activity. Black women are less physically active than any other population group. Now, let me tell you, we do not like to get our hair messed up. And you guys that are in the audience, you guys know that. But let me tell you, there's ways to do it out. You guys talk to me afterwards. We'll show you how to do it. Because they call me the mayor of my gym. And I have some gym people here that will attest to that. All right? But let's look at how this might disproportionately impact groups and what we have to pay attention to. So having any two of these factors, high blood pressure, high triglycerides, low good cholesterol, so that would be our HDL cholesterol, impaired glucose metabolism or a large waist. And for women, measuring at the umbilicus, which is our belly button, if we have a waist that is greater than 35 inches, that's what we're talking about, these may increase the risk of heart attack and stroke in Black women with obesity by 117%, but not in white women with obesity. So we're not understanding why these factors play a larger role, particularly in Black women. And when we look at issues such as high blood pressure, diabetes, stroke, some of our 3 primary killers, what we find out is that African Americans are more likely to die early from all causes. And even when you control for socioeconomic status, graduate level education, we are still seeing numbers that are disproportionately higher in persons of African descent here in the United States. And you can see that becomes more pronounced as we climb the age ladder. So I know that BMI isn't the best measure to look at, and so I actually did an entire analysis of NHANES, the National Health and Nutrition Examination Survey, for the last 15 years to look at whether or not the BMI cutoffs that we have by race really give us information that can inform us in the clinical practice. And what I found in my analysis that came out last year in the Mayo Clinic proceedings is that when we actually look at comorbid conditions such as high blood pressure, high cholesterol, and diabetes, that for men almost across the board, remember the BMI cutoff was 30 for obesity, it actually shifts downward, right? So if we're looking at really picking up risk, it shifts downward almost across the board for men, whether Black, Hispanic, or white. For women, I want to point out specifically here, Black women particularly, you can see that there's a slight shift up in terms of our risk for issues, and you can see that there's a shift up to 31 or 33 with an exception of high cholesterol, which we see as 29. There's a shift down for many of the other groups that are noted here, specifically Hispanic and white women, when we look at the BMI cutoff based upon obesity-related comorbid condition. So let me teach you guys a little bit about obesity before we wrap it up. And what we've learned is that obesity is pretty simple. It's all about calories in and calories out, the food and beverages you take in, and the bodily functions and physical activity. If we just balance these, we should be exactly the size we want to be, right? So if we want to be a size 2, we should be a size 2. If we want to be a size 6, we should be a size 6. That's women's sizes for men. I know you guys have all that, those measurements and things. But we know that, unfortunately, that it's much more complex than this. And if we continue to use this mantra to look at how we look at obesity, we'll continue to fail in addressing this disease that is as prevalent and is unfortunately the most prevalent chronic disease of our time. I'm going to start at kindergarten, work ourselves up to PhD level, and then we're going to bring it back down to kindergarten, and then we're going to wrap it up. But what we should know is that all calories are not created equal. So if you look at the left side of the screen, we have a slice of pepperoni pizza. On the right side of the screen, we have a plate with quinoa, chickpeas, roasted red peppers, carrots, 350 calories on the left, on the order of about 700 calories on the right. So if it was all about calories, I should just eat this, right, you guys? I should just eat this. But what we do know, it's not about just the actual diet, it's about the quality of the calories one's taking in. But just because I eat this way, doesn't mean that I will be exactly what I want to be. And one of the key reasons is that weight is more heritable than height. I'm going to say that again. Weight is more heritable than height. Meaning if you have parents that have obesity, the likelihood that you indeed will have obesity, no matter whether I breastfeed you for the first year or two after you're born, puree your foods from Whole Foods, the likelihood that you will have obesity yourself because of the cards you were dealt, because of the parents you were born to, is on the order of 70 to 85%. If children are born to tall parents, we automatically presume that the kids will be tall. But what we don't know is that it's not about bad parenting, it's about the vessel through which that child traveled, that if they have parents that have severe obesity, or even grandparents, if we look at epigenetics, that the likelihood that they indeed will struggle with this disease of obesity is by far high. So what we do know is that obesity is a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having this disease of obesity. And I'm about to get very technical for you so that you can understand that obesity is super duper complex. What really controls how our body regulates weight is actually the hypothalamus. The hypothalamus, which is here, centrally located in the brain, is getting signals from our fat tissue, our large intestine, our small intestine, our pancreas, and our stomach is sending signals back via this vagus and spinal nerves to tell me not only how much to eat, but it also tells my brain how much to store. So I want you to think of us as having a gas tank. Some people that are very lean may have the gas tank the size of a little smart car, those little cars that can fit in all the spaces, and their brains defend a low set point for weight. Persons that might have severe obesity may have the gas tank the size of an army tank, and their brain does whatever it can to hold itself at that much higher level. This is going to be the most complex slide, but hang in there with me, and then I promise I'll bring it back down to 8th grade level. So, leptin is a hormone that signals from fat cells. It can travel down one of two pathways in the brain. If it travels down this pathway, and this neuron, which is called the POMC, or the pro-opiomelanocortin neuron, fires in the brain, these people get an anorexigenic signal, which decreases their food intake and decreases their storage. They have high levels of what we call brain-derived neurotropic factor, and good for them. My husband is a classic example of this. For the last 26 years that I've been with him, he defends a set point of somewhere between 155 and 165 pounds at 6 feet tall, and that's great for him. And he still goes for donuts most evenings. And that's great for him. But my patients deal with an alternate pathway where a different neuron, the AGRP, or the Goody-related peptide neuron, is then firing. It inhibits or blocks the formation of brain-derived neurotropic factor, and these patients receive an orexigenic signal, which is the opposite of anorexigenic, which not only increases food intake, but it also increases storage. So here's my 8th grade rendition of this. The brain is getting signals about our diet quality. We want it to be a diet where we have lean protein, whole grains, fruits, and vegetables as our predominant sources of intake, but just because we do that doesn't mean that we can overcome things. We also really pay attention to physical activity, but we sell the wrong message when we're looking at physical activity. Physical activity does one primary thing when we're looking at weight. It does a lot of things for a lot of things. It improves our heart health, our mood, etc. But on average, physical activity helps us to maintain our weight. On January 1st, everyone joins the gym to do what, you guys? Lose weight. And then on February 1st, which has already happened because today is the 5th, they stopped going to the gym because what happened? They didn't lose weight, right? Because the message is wrong. On average, physical activity helps us to maintain our weight. So I'd say people go join the gym this year to maintain your weight, because there are people that are gaining, 5 pounds each year. And if we extrapolate that out for 10 years, we have 50 pounds of excess weight. So, but the messaging is wrong. What we do know is physical activity helps us to maintain our weight. Sleep quality and duration does play a large role in how the body regulates weight. We know that high quality sleep is important to weight regulation, and I do a whole hour-long lecture on that. We won't go into that today. Medications that we as doctors prescribe can contribute dramatically to weight gain. I'm going to go through a laundry list of medications that you hopefully will pull some out of here that can cause significant amounts of weight gain. Everything from lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Prozac, Ambien, Trazodone, Lunesta, Gabapentin, Glyburide, Glipizide, Glimepiride, long-term insulin, long-term prednisone, antihistamines, IVF medications can cause significant amounts of weight gain. So much so that I think it's imperative for us to pay attention to what medications people are being prescribed, because just making a shift can cause drastic changes. For example, my hairstylist, not my current hairstylist, but one of my previous hairstylists in Boston told me, Doc, I'm concerned. I've gained some weight. I went on this new antidepressant, and I've gained some weight. And I asked her what drug she had been put on. And I was like, no, tell your doctor to shift you to this antidepressant, because that one that you're on can cause a bit of weight gain. I went back to see her in 8 weeks. She has shifted medications and lost 25 pounds. So the goal is to recognize the role in how these medications act on the brain to shift weight set point, and not immediately blame individuals that have obesity. Circadian rhythm disturbances are also of significant concern, meaning if you're awake during the night and asleep during the day, that shifts how the brain sees weight. And so we want to make sure that we're aligned more with natural patterns. And then thermogenesis, which is just the cards we're dealt. How much we burn with rest and with activity, a lot of that's genetically determined. And so all of these factors play a role. I'm going to show this slide to show you the complexity of obesity next. The reason why that first slide I put up was incorrect with calories in, calories out is that these are all the factors that we know of as of right now that affect persons and affect their weight. Things that happen inside of an individual here on the left, things that happen outside of an individual here on the right. These things here on the top increase one's intake. These things here in the bottom decrease expenditure. And then these things that are here across, they affect either intake or expenditure, or we haven't figured it out. Now we'll look at the key categories that are contributors and influencers to obesity on the previous slide. We can have either biological or medical reasons why someone struggles with weight, maternal, developmental, social, psychological, food and beverage, behavior and environment, and economic. I would say that we spend all of our time in medicine and in public health focused here, but not realizing that these other areas are by far more pervasive. And then environmental pressures on physical activity. Last scientific slide, I promised you guys, but I think it's important for us to recognize this BDNF that we talked about. High levels of BDNF, brain-derived neurotrophic factor, being characterized as leaner, right? Those that have low levels, not as much. So what they did was this large study looking at 31,000 individuals. And what they found was that this BDNF blocked the transcription and activation of this allele. And what they found is that if you had a CC pair, that you had low levels of BDNF and tended to have obesity. If you had a TT pair, you tended to have high levels of this brain-derived neurotrophic factor and tended to be lean. When they looked at this by race, they found that persons that were Hispanic and African American were much more likely to have this CC pair than other populations. So maybe one of the things that accounts for the difference that we see is not just those things that we think about, the differences such as physical activity in Black women, like I mentioned earlier. Maybe there's a large genetic component, and indeed there was a large GWAS, or genome-wide association study, that was performed by the NIH, and they showed that in African populations, those born and raised in West Africa, and those that are persons of African descent born and raised here in the US, that there was a 5 BMI point difference associated with certain genetic traits that predispose to obesity. So some of the things that we might look at in public health is, how does income affect obesity? And what we find is that women with lower income actually have higher obesity, and that's probably not that surprising. But what may be surprising is this next slide, is that non-Hispanic Black and Mexican American men, and this is taken from the National Center for Health Statistics, actually have higher obesity rates at higher income level. And what you can see here is that as they climb the socioeconomic strata, men that are from these two predominant minority groups here in the US actually have higher obesity levels. Some of the things that have explained this are due to the higher stress that these men then experience once they climb the ladder. They're no longer just caring for their core unit, they are responsible for the care of a much larger family unit, whereas in non-Hispanic white men, they will typically be caring for their smaller family unit and not have the stressors associated with that climb. Despite the fact that we saw that ethnic minorities have higher obesity rates, when they looked at NHANES data to see how often a person actually received a diagnosis of obesity, you can see that non-Hispanic Blacks and Hispanics were much less likely to actually receive a diagnosis despite the higher prevalence of obesity. And so some potential reasons have been posited for ethnic disparities in obesity. Maybe we eat more, increase energy intake, or retain more energy. Maybe we just don't work out as much. Maybe our bodies don't burn as much with thermogenesis. Maybe there's issues, life stressors, racism, which we've talked about today, lack of career options, family illness and death, which really cause greater issues with obesity within ethnic communities. Cultural influences have been posited, genetics, which we talked about. I did write a book that came out last year in which I addressed all of these issues called Facing Overweight and Obesity. It came out of Mass General. I really tried to delve into some of the issues that a lot of people don't commonly hear about when we're talking about obesity within communities of color, and also a majority population, both in the pediatric and adult population. So let's close with the following summary. Racial profiling is alive and well in the United States. Racial profiling leads to inequities in care for patients and challenges for providers that deliver care. Strategies to address racial profiling should be developed to allow for optimal health and lived experiences for racial and ethnic minorities and those providers who render their care. I want to thank you so much for your time. I'm going to stay around to answer any questions that you might have. I want to thank you so much for your attentiveness during this presentation. It was very personal in many parts. And I want to thank you for allowing me the opportunity to share my story and my truth. Thank you. All right, so I am open to answering any questions that anyone might have that covers anything that we went over, because we kind of went around the world and then back. Any questions that you might have? I think there's someone centrally. They're going to come down and bring a mic to you, okay? Oh, you project? You project? But I think it's on the live stream, so they want to pick it up. So.
Okay.
I know. I'm one of those people.
I'll deal
too.
with
I get
it. So just this is not really your responsibility to know this, but I was just curious if you had any ideas for your last bullet point, where you're saying on your previous slide, where you were saying like for next steps needing strategies to adjust racial profiling. Are there certain strategies that you have in mind?
Well, I think that we have to have both majority and minority groups coming together to talk about the lived experiences that people have. Often people don't realize that, on a daily basis, there are things that a person of color might face that you might not be aware of, because it's not just your lived experience. And so allowing us to have the opportunity to have forums of this kind where I can speak, but I can't speak for the entire population. The lived experience of what persons of color experience daily need to come forth so that we can begin to address them. I don't think naming a chair of diversity or any of these things will immediately solve the issue. Oftentimes what happens when groups name a chair of diversity, equity, inclusion is that they don't give them the infrastructure or space to really create change. And so they are brought in and set up from failure at the very beginning. And I think that that's problematic. We have to have buy-in from both the majority and minority groups coming together to find solutions that are tangible in each area. So I don't have the answers, because the answers vary from person to person, group to group, but we know that the issue is there. Now we have to figure out how to address it. And I do believe that if we're looking at issues such as bias and how we profile, a lot of that comes from our learned experience, right? So we learn where our place is in this world pretty quickly. Before this talk, I had a chance to meet with some students that were all immigrants to this country, and one of the students, I won't name her name, said to me that when she got here, she felt confused about how she would label herself in a demographic survey. She was born and raised in Nigeria, and so she now was supposed to pick that she's black, but she's like, I think of black as someone like me, born and raised in the United States. But she's black, but she never had to identify herself as that, because so was everyone else in Nigeria. She would identify herself by basically her geographic location. And then she realized that, wait a minute, everyone else sees me through this lens. And with that comes a different set of learned or lived experiences that she didn't have. And she says that, I speak from a place of privilege, because growing up, I only saw persons that looked like myself achieving. That's not the lived experience of most of the people that look like me here in the United States. I grew up in Atlanta, where I did see, and actually my zip code has more black doctors per capita than anywhere else in the United States. So I grew up with a different lived experience than even many of my colleagues that grew up here in Boston. But we have to hear the voices. We have to allow the voices to come out and shape the conversation and change it in a positive way. Does that hopefully address some of kind of the answer to that question? All right. Other questions? I think there's one in the back corner here. Yes.
Hi, thank you for coming in. I'm Jason, one of the chief residents here.
And which discipline?
Internal medicine.
Oh, wonderful. Excellent.
So,
I'll rope you into some other things. He doesn't know he's signing up for things.
And my question is, it seems like the further you go up the ladder, the corporate ladder, hospital ladder, academic ladder, we experience more stress to us. So I want to know if you had any personal strategies to help you relieve some of the stress. How do you address some of these things as they're coming up in real time, and how do you reflect on it when you're looking back?
Oh, this is a really great question. And I, first of all, congratulate you for being one of the chief residents in medicine. And I think I want to acknowledge something that's a key point I didn't say in my talk, but as a black man in medicine, I want you to know that the number of black men entering medical school in 2020 is less than in the early 70s here in the United States. That is the reality that we live in. I'm sure you knew that. 1970s, 2020, just a few years apart from each other. I mean, I'm being a little bit facetious, but you can see that we're having this significant decline. And as you continue to rise through that ladder, people are then questioning your abilities, questioning whether what you said was indeed what you said, questioning who you are. And I would say the one thing that I do to really navigate this is I, have used my role. So right now I'm the vice chair of the Minority Affairs section for the entire American Medical Association. I use that role to begin to leverage this conversation throughout all of medicine. Thankfully, as I've climbed the ladder, my voice is allowed to be heard, but I still face inequities. I can tell you that at my lovely hospital, MGH, I hope you're listening, that I'm paid less than people that have significantly less education than I am, that I'm promoted less likely. I have a 93-page CV. 93 pages, you guys can go look online for yourselves. I was promoted to assistant professor last year. Really? I mean, you don't even have to be someone in academia to realize that that is indeed despicable. I also have to recognize that when I say things like that, I'm holding myself accountable and holding myself up to this idea of having to speak my truth, but recognize there may be repercussions because now I'm the angry black woman. It's not about being angry. It's about having 4 degrees, 2 residencies, 2 fellowships, and having a 93-page CV. The credentials are there. But as a black woman, I'm not supposed to say that, what I just said to you. But I feel like if I don't say it, then you can't know that that's my issue, right? Now you've heard it. Well, they've heard it before, but you're hearing it again. I just got to say it in as many venues as I can. But now you've heard it, right? I'm also one of the founders of Times Up Healthcare. I think it should have had a slide up of that. So Times Up Healthcare looks at issues of fighting inequity in healthcare. Many of the issues have been on gender inequity, but one of the issues or the reasons why I was brought in as one of the founders in this group is because I really delve into this issue of race. So you guys may have noticed at the State of the Union address, and we won't get into the content of the State of the Union address, but all of the congressmen women were wearing white in solidarity for when the first white woman was allowed to vote here in the United States. I specifically said first white woman because black women were not seen as equal and we were not allowed the right to vote. But that was a suffragist movement. And so often there are issues when we're looking at, let's say, gender equity where we forget the race piece. And I know that when I walk in the room, the first thing people see is that I'm black and then a woman. And then the combination thereof puts me at a different status. All right? And so I think that you have to learn your truth, learn what you feel comfortable with. I have a medical student that's at Harvard Medical School now, and she knows who she is. Hopefully she's listening to me right now. She says things that I wish I could say, but I also have to keep my job. And she tweets it. She'll be like, can you believe such and such? And I'm like, oh goodness. But then I'm like, that's her voice. And she's gonna, as she continues to grow in medicine, she will allow her voice to shape, and maybe she will have that bold audacity. Why not speak your truth? Why can't I speak my truth? Learning to navigate that is important. My faith is extremely important to who I am. My first memory in life was indeed my christening, I think, for a reason. So I have to draw upon that to get me through a lot of the tough times that I get through within my professional life. Because if not, it could drive one crazy. So I think it's one of those things that you're going to constantly find ways and strategies. Are going to use the platform of organized medicine? Are you going to use faith? Are you going to use your exercise endeavors? Are you going to use a combination thereof, which is what I think I do to really get myself through what I see as my daily challenges? So hopefully that explains or answers you, but I appreciate and acknowledge as a black man in medicine the struggle that you have, and know that just keep fighting the good fight, I think is the key thing I want to say. Yeah, thanks. She's going to bring the mic to you. Yes.
Hello.
Hi, dear.
My
What's your name?
My name is Eno.
Okay.
I'm a software engineer at the Broad Institute of MIT and
wonderful.
Harvard.
Yeah.
Yeah, and I'm also the corporate relations lead for NSBE Boston. Check out our events for Black History
NSBE is the
Month.
National Student of Black Engineers, or
Yes.
right? So
Yes.
I have some not thoughts there. Okay. Yes.
So just like in line with what you're saying, as like people, like I have the belief that closed mouths don't get fed.
Okay.
And you can
So say it a little. So talking to the mic. So she said
sorry.
closed mouths don't get fed. But
Closed
I don't know
mouths don't get fed, and as we are saying the issues that we're experiencing, and then for those of us who take the initiative to actually develop programs to make it easier for people who are experiencing the same thing, but at the same time, it's taking our away from our day-to-day responsibilities. And so the programming that we really need and others need as well, we end up being penalized because because we're away from the desk, we have to make up the time. That we are using to create these programs to benefit ourselves. And so my question to you is, like, how have you navigated that? Just overall, how have you navigated that? What advice can you give?
So I think what you're talking about is what we consider to be the black tax or the minority tax, which means that if I am a person of color, often I'm pulled away to do all of these things to represent the black voice. I already have told you guys that my voice only represents my voice. It doesn't represent all people that look like me. But often in groups, especially like the Broad Institute at MGH, you find yourself that you are the only person that represents that voice. And so then you get pulled away. And it's unfortunate because I think that majority groups need to learn more about what it's like to live our truth, right? But that needs to come, unfortunately, because many of the organizational structures are a top-down approach, right? So if the top line individuals have not yet identified that that's a major issue, you're going to see you at the bottom trying to do all of these things and then never quite making it because the top didn't believe that it was of importance. And so I think that we need to have it, and I'm going to come back to my response to the first question that was asked, that the top line people, since we do have this top-down approach, really need to take this up as a system-wide initiative. This isn't just your problem. This is a system-wide problem. I can tell you I was quite dismayed on January the 24th of this year, 2020, when I went in to teach the medical students at Harvard Medical School in their first year class. And after I finished teaching, I was told that I was the only black faculty that they've seen this academic year in any of their core classes. And I was hurt because here I am on the faculty teaching these students who are just wanting to have someone to potentially validate their lived experience in this Harvard Medical School setting and not ever having an opportunity to do that because they didn't even see any of us there. There's only a few of us, so there's a problem there, but that has to start at the top. What are we doing to recruit and retain underrepresented minorities in medicine at arguably one of the best medical schools in the country? It shouldn't be an issue, but it is an issue. It's an issue we live every day. But when you're not treated well or you feel like you're having to claw your way up, why stay? Right? So I would say there's not an easy answer to that. But I do think that we have to have allies at the top really deciding to take up the banner, to recognize that people that look, eat, breathe like us also are deserving of success, also deserving of praise, and also deserving of award. So hopefully that helps you in terms of how I think about it. There's a question here at the back of the room here.
Hi, my name is Bola. So my question is, in addition to what she said about closed mouths don't get fed, as a Black woman, I also think about we being at the forefront of this conversation, talking about diversity, inclusion, oppression. It does get exhausting. To where sometimes in my personal life, I just see it and I'm like, I'm tired. So how do we incorporate like mental health? Because I think we also don't talk about mental health in the Black community and also its intersection with systems of oppression. So how do you like navigate that conversation?
If we could answer that question, we would be in great position. But I do think that we have to have these conversations with each other. Often because there's so few of us in many spaces, instead of coming together, we're often competing with each other. And instead of aligning with each other in such a way that we can begin to have these conversations in group settings or take care of our own personal health, we end up finding ourselves tired, just tired. I just am ready to stop. And that's not where we want us to be, but I think that we have to be open and willing to express this to each other, but recognize that we have to use each other as allies. I can think of my students, my residents, my fellows, and I never want to push them down. My goal is to bring them up, and if they surpass me, great. That means that I did a great job. But often we're in situations, especially in predominant institutions, where we don't see that to be the case, and we are our own worst enemies. So how are we going to come together if we don't even like each other, if we don't even want to be in the same room together because we're competing for that one spot, right? And so I think that we have to have open conversations about this. I appreciate you for bringing this up. Mental health issues within the Black community, for example, are issues that are of significant importance. One of my high school classmates, who was a psychiatrist practicing, who graduated from Morehouse School of Medicine, did unfortunately commit suicide within the last 14 months. And you can imagine, as a psychiatrist who cares for persons that have mental health issues, a Black man committed suicide. I don't know the story. I don't know the full story. But what if he had an outlet to express whatever he was feeling? I think the outcome would have been different. So we have to have those conversations. That's a conversation, for example, around like physicians as a whole. 400 physicians each year in the United States commit suicide. We are one of the highest professions for suicide outside of even the context of race. That'd be a entire lecture, but I think that we have to embrace this and recognize that we're not doing a good job. So I appreciate you for bringing that up. Yes. Other thoughts out there? Yes.
This is wonderful. It's great to see you again.
It's good to see you. So this is my classmate from the Harvard Kennedy School. This is Craig Kelly. He is one of our city councilmen in Cambridge. So
I was until the last election, but that's okay.
Oh, okay. Well, he was for a long time.
Yeah, that's true. So how do you deal, how does the Black physician deal, and this is my story, right? Because you know Dr. Riley, she was our obstetrician. And how do you deal with the white people that come in and, you know, every professional interaction we've ever had is with a fellow white person, so we know what they look like, we know how they speak, we know everything about them, and you open the door, and there's a Black lady who's gonna eventually cut your wife open and deliver your baby. And it all worked out great, and she's absolutely fantastic, but I mean, she must have dealt with that 10,000 times, and
Right.
you must also. So how do you prepare yourself and coach people like me to realize that the reality of the world isn't always as I see it?
So that's, I think, a good question, Craig. I think that, you know, I don't know. I think now that, you know, in obesity, having done more training than anyone in the U.S., that people typically know who they're going to get and wait for 9 months to see me. So they typically know what they're getting. But I have had experiences at Mass General. I had a woman that I went to, I actually go get my patients from the waiting room. I don't wear a white coat except for photo shoots. So if you guys see me in a white coat, no, it's only a photo shoot. I know where my white coat is, but I don't wear it because my dresses are so cute, right, you guys? Beside the point, so what ends up happening is I went to the waiting room to get this woman. You know, hello, my name is Dr. Stanford. She comes into the office, which has Dr. Stanford on the door. My cards that say Dr. Stanford is sitting there. I do a 10-minute, you know, kind of introduction to obesity, blah, blah. And then she says, well, that's lovely. When do I get to meet the doctor? And I was like, well, okay, okay. And so I didn't know how to respond immediately. And I said, excuse me? She's like, well, that was lovely. I appreciate you for going all of those things. So when do I get to meet the doctor? And I said, I am the doctor. You were the doctor? And I'm like, yes, you waited for 9 months. I mean, I don't think she knew that she waited for 9 months to see me, but, oh, I didn't know. Now, she did not return to see me. My patients do typically return, but I think that she had in mind a different picture of what this doctor was going to look like. I don't really face that very much anymore because of how I've progressed in my profession. But I think that the reality is that you have to recognize that we were physicians in Africa before we became slaves here in the United States. When we were enslaved people, you weren't bringing slaves over, you were bringing doctors, lawyers, architects. That's who you were bringing to the U.S., who then became, once we were allowed to learn to read again, the same doctors and the same people that were discovering key issues in medicine here in the United States. So I think just be open to the fact that anybody can be anything. And if we have that in mind, and if we have people that are allowed to show that, hey, it doesn't matter what your skin color is, that you can be anything that you set yourself out to be, but recognize that the barriers that might exist for those persons of color to reach that level are indeed going to be steeper, higher, stronger, tougher throughout their entire existence here on this earth. So he was speaking about Dr. Laura Riley, who was at Mass General and is now the chief of OBGYN at Cornell in New York City, arguably one of the best OBGYNs in the United States. I would say that we have a similar look kind of thing going there. Dr. Riley, if you're listening, that's you know, of course, a compliment there. But you do see someone that looks like me, and then you have to decide, how do I navigate this? Do I assume that they are lesser than just because they look like me? Do I assume that their education is not as ideal? Do I assume that they're not able to navigate their way in the OR the way as someone that's a white male? And those assumptions, those biases, we have to rid ourselves from. And so, Craig, I would say do the work. Do the work, you know the deal. Do the work so that you can make sure that other people are aware that, hey, they too should be equal. That's my response there. Yes, there's some questions up in the front.
Another hand there. Okay.
There's two. There's two.
Hi.
Hi.
My name is Confidence.
Confidence.
Yes.
Hi, Confidence.
Hi. So I'm just curious as to how you were able to cope with the incident in your first year of med school until you finished, and how has that affected your relationship with your colleagues from med school, if you see them recently?
I don't see them. So I'm sure they see me because I tend to be in whatever your local newspaper or whatever most days. But so I don't communicate with most of my colleagues from medical school for obvious reasons. There are a few key people that I have kept in touch with over the years, but I would say a very, very small group. And the way that I got through it was my faith. I told you is very important to me. My medical school is in Augusta, Georgia, which is 2 hours from Atlanta, but I drove to Atlanta, Georgia to church every single Sunday for all of med school. I missed 2 Sundays. So it was a 2-hour drive there, 2-hour drive back, round trip, 312 miles. The reason why I was going and doing that on Sundays was because I needed to get fed. I needed to feel as though I was validated and I needed to have my worth. My family also happens to be in Atlanta, but I was typically spending time at the church and coming back because I had to be in class the next day. So I would say that my faith is what really got me through. I do have to give credit to my parents, my sister, my husband, for really being there and having to foot the burden of that. My husband probably the most because he was living with me. My parents didn't have to navigate that every day. But you can imagine that starting med school and having that be the issue. And one thing I did not mention, which I'm surprised I did not mention, is the first week of med school, my maternal aunt died at the age of 45, right before my first anatomy and physiology test. She died unexpectedly, and she'd been trying to call me during that first week of med school. I didn't call her back because I was like, I got to get through this first test. I'll call her right after the test. She died the day before my tests. So I was dealing with that, right, plus this other issue, and it felt often how am I going to make it? But I felt like I had been put there to do that work for this time, to even be here to say this to you, and I had to push forward. And I used the combination of my family, my faith, to really help me propel myself through that. Sorry.
Hi, my name's Chiara. I was wondering, so I come from a country where obesity is basically the biggest killer.
Where are you from?
Bermuda.
Bermuda, oh yeah.
And our government, which is a majority black government, decided that to combat this problem, they were going to introduce a sugar tax. So I'm just wondering, what was your opinion on the effectiveness of that?
Yeah. So thank you for answering about that. I actually have been consulting with the Bermudian government to help them begin to develop a more strategic strategy to approach obesity in Bermuda. I don't think it's going to work, right? So if we think that it's all about sugar, then I wouldn't have that complex slide, right, that I just showed you. But it's nice to kind of put a blame on one thing, right? But what we do know is obesity is multifactorial, and every place that we've put in either a sugar tax or menu labeling, we haven't really seen any rates of obesity decline. It makes us feel good about ourselves. Hey, we did this. But did it shift weight status? No. But it makes us feel good because somebody else did it. And so I think that you have to have a more dedicated strategy where you're looking at schools, where you're looking at family environments, where you're looking at faith-based institutions, bringing all these groups together to address the issue of obesity from a multidisciplinary, multifactorial way. And it's hard work. And so there was actually a lovely article that came out just, I think, in the Wall Street Journal a few days ago that said that obesity is by far harder than rocket science because each of us have such different variation in our bodies that predispose us in a different way by different mechanisms that cause us to have obesity. But if we want to look at a population-based approach, I want to just put something on a group, right? A sugar tax, and if I put the sugar tax, we presume that weights will go down because people won't buy those sugary beverages or, added sugars. If people want it, they buy it, right? So what I thought was very interesting when I gave lectures in Italy recently is that on all of the cigarette boxes in Italy, they have these things where people are dying, their guts are falling open. It's really interesting. And so they're all on the shelves, right? And then everybody's coming in and buying those boxes. They never look at the images. They buy the box, they put it in their pocket, and they pull out the cigarette. So if people want that nicotine, which is a drug that they're addicted to, the labeling didn't shift their behaviors. Actually, there were more people smoking there than here, even though the labeling was such that you would think, oh my gosh, this person's dying on the package. If I don't look at the package, I still get my cigarette. So does that make sense? So I don't think it's going to solve the issue. I think it could be one of 100 potential strategies, but by itself, not one single measure is going to shift, the rate of obesity. So, but I appreciate you for letting me know. And I understand what's going on in Bermuda very particularly. I'm actually now licensed to practice obesity medicine in Bermuda as of December 1st because of this very reason. Yeah, thanks. All right, I think there may have been one question in the back. Yes.
Thank you so much for sharing. Really appreciate it. So I work for a telehealth company, and there's a big emphasis.
Telehealth?
Telehealth,
okay.
yes, telemedicine. Okay. There's a big emphasis on allowing patients to choose their own provider, and there's a photograph. So you would assume that their racial biases probably come into play when they're choosing a provider. Right. So my question to you is, do you think that's appropriate? And then secondly, just more in general, how do you balance this idea of we want to preserve patient choice, and at the same time, if they're making choices that are going to prop up an inequitable system, how do we respond to that?
I think that's really tough. I mean, at MGH, we won't allow telecommunication unless an in-person visit has occurred. So my patients, I do telehealth visits with my patients where they come on the screen, but they already know what I look like, right? Because we've already spent time in the office. And so I would say in a system like that, you're not going to have as much of an issue where you're not picking me as the provider. You're now following up with your care. And so I think that if we switch to models that are more like that, where they have the initial in-person consultation and then subsequent care happen in the telemedicine model, you'll have less of those biases. But if we look at it, when we look at who people respond to most, so people of color tend to respond better to doctors of color because they look like them, they feel like they understand their experience, but often persons of color don't have access to enough people that look like me. There is indeed only one Black physician that practices primary care medicine at all of Mass General. So let's say you were going and you were searching for a Black doctor as a Black man and you wanted to have a Black doctor, there is one, if you can get in with him. And so the issue ends up being a little bit more the opposite of that. It's not that there's typically not enough of us to go to the population that would want to seek us if they indeed knew that we were available. And so there's that issue I say is a bit more commonplace. But I think it'd be interesting for you to do some type of analysis. You have a lot of epidemiology and biostatistics students in the audience today. I know quite a few of them that might look at an analysis to see what are influencing their choices. Is it the picture? Is it the degrees? What is it that's influencing that? I can say, being and practicing here in Boston, that people tend to care a bit more about how many credentials I have. Whereas in another place, it may be less of an issue, But here, a lot of my patients come in and bring the latest New England Journal article to tell me about the study that I already knew about. But they're like, yeah, but this, yes. And I'm like, yes, I already know that. I reviewed that article, but we can get to it. So, it just, and also there's going to be those geographic differences, right? So from the previous person who is from Bermuda, what they may seek and desire may be very different than Bola, who's in the back, who's from Nigeria, what they want. And so you have to kind of look at the nuances between the population, but use that initial consultation to then spring into telemedicine, which is by far a better way of kind of having continuity of care for patients. Does that hopefully help? Yeah. All right. Okay, so I think that we are done. I want to thank you so much for your attention. I really appreciate your attentiveness today. For those that are online, thank you also for tuning in. I will stay around because I think there are quite a few questions that maybe some students have, and I'm willing to stay around and answer those. Thank you so much for having me, and thanks for letting me tell my truth.